Hi, everybody. I just got a question from someone named Michelle in California. She's a doctoral student, and she wants to know, I've been diagnosing for a year and a half now, clinical cases, mostly fictional ones. I feel very uncomfortable when I diagnose cases. It seems to me that I'm putting people into a box, and I feel that it is an unfair and maybe even unjust thing to do. How do you resolve this problem? So I really appreciate this question. I've actually been asked this question many times in the last several years. I've been teaching psychodiagnosis for a long time. It was actually the first thing that I started teaching at the graduate level. And I think there is a relatively straightforward way to resolve this problem. What I'm going to propose, of course, not a complete resolution to the problem, but it might actually help you find some comfort with what it is that you're doing. Now, of course, I do want to start by saying that it's never acceptable to reduce a person's problem to a category and therefore believe that you have somehow um, captured or understood them entirely. So that's never going to be something that you should be comfortable with. Now, the, the next thing I can suggest is this. I think it's important that you first understand what the Diagnostic and Statistical Manual of Mental Disorders actually is. This book, the DSM, is a book of conceptual categories that help us organize psychological phenomena in a way that helps us understand them, grasp them, and communicate about them with other people. So, in that sense, the DSM is actually giving us conceptual entities rather than real entities. And by conceptual entity, all I mean is that they give you a concept that organizes several different real phenomena into a structure that is usable. A real entity would be something that once named you could actually point to in the world and actually find the actual thing being referred to. And that's very difficult with psychological phenomena, which are so blended, complex, and unique to the individual. Nevertheless, as a conceptual thing, it can prove very useful. Now, once we have an understanding of the DSM and its disorders as conceptual entities rather than real entities, we now have to go back and look at what it is that we're doing when we're diagnosing. Are we diagnosing people, or are we trying to diagnose clinical phenomena? There's a very big difference between these things. I don't believe that it's just a sleight of hand. When we diagnose a mental disorder, what we're diagnosing is a cluster of phenomena that happen to come together in one individual. We are diagnosing the struggle, you can say, rather than diagnosing the person. The way that this helps with your problem, Michelle, is that concepts are always smaller than, less real than things in the actual world. So when you apply a category to a person's struggle, you're never putting the person in the box. You're simply organizing the phenomena. In the organization of the phenomena, the person will always be bigger, more complex, and free from the category that organizes the phenomena itself. So we don't diagnose people, we diagnose clinical phenomena. I find this to be a very helpful way to think about psychodiagnosis, and I hope that it helps you too.